Hi, my name is Cliff Robinson. I'm a radiation oncologist at Washington University in St. Louis. I'm the director of the Cardiothoracic and Stereotactic Body Radiation Therapy Services and director of clinical trials. We've all had patients that have had an exceptional response to treatment above and beyond what we really could possibly have hoped for. One particular patient I can think of was an elderly gentleman who had metastatic adenocarcinoma, no driver mutations, had a PD-L1 high, initially got chemoimmunotherapy, and was on immunotherapy maintenance. During the course of his immunotherapy maintenance, he was found to have a single progressive lesion that was actually his primary or presumed primary. And the discussion was about switching to a different therapy versus a increasingly common practice of instead delivering focused treatment with SBRT to that lesion in an effort to try and sterilize the progressive clonogen and maintain his ability to continue on a very effective and also very tolerable systemic therapy. So this notion of delivering stereotactic radiation for so-called oligoprogressive disease is becoming increasingly popular, despite the fact that it hasn't really been rigorously tested in clinical trials. Those trials are ongoing. However, in this case, what I saw was something that was not expected. After we delivered SBRT to the primary lesion, despite the fact that he had been on immunotherapy maintenance now for the better part of half a year, within his next scan, all of the lesions that were on his scan responded. This is a description of something that we all have been chasing for quite a while, which is the so-called abscopal response. And I have to admit that I, started to question whether it existed kind of like unicorns, because it's something that we often chase with this idea that we will use SBRT to trigger, an increasing immune response that will then trigger the remaining sites to then also respond. And this was something that was textbook abscopal. The difference is that it was somebody who was already on immunotherapy, as opposed to where we've often been trying to chase it, which is in the upfront setting in patients who have newly diagnosed metastatic lung cancer, where they will get immunotherapy and then SBRT to one or two target lesions. The other interesting thing about this case was that the patient suffered from a significant pruritus from his immunotherapy. He was having a dermatologic adverse event and required topical application of steroids. Following the SBRT and the increasing response in his other lesions, he actually had an increase in that adverse event, and it was getting worse. For the period of about a year, he continued to suffer from that. And then interestingly, almost overnight, his symptoms resolved. He stopped needing the steroid cream. The itching really responded on its own, and he felt a lot better. And then unfortunately, on his next scan, he had dramatic and widespread progression of his metastases. Really, for me, an eye-opening moment thinking about the crossover between the immunotherapy effect as an adverse event and then also on the tumor as well. So this is somebody that I still think of all the time when I think about the abscopal effect and also the potential utility of delivering consolidation SBRT in patients who otherwise have single progression on IO.